quality health services provision to Rwandans, to people living in Rwanda, let's say a reality. Now we have a challenge when it comes to plastic surgery. It is a need. It is an expressed need. We have been seeing this all the time since we are young. But now at least we have a small capacity together with our partners to handle as much as we can. I mean, in terms of cases, not only in the Kigali city but across Rwanda. So that is somehow achievement. But it is not sustainable if we continue just to have two plastic surgeons or support from outside. So we need to build that capacity. And the Ministry of Health, together with the Ministry of Education, School of Medicine, Dr. Foster, Dr. Charles Furaha, they tried really, but it is not enough. So we need to train other surgeons, we need to train other healthcare providers, and to build a strong system and expand the offer in terms of plastic surgery.
So of course everybody knows Dr. Faustin. There is no need for me to just say, but I think one thing we've used that has been very significant to what Dr. Faustin has said time and time again is that don't give us fish, or that adage that says give a man a fish and then you feed him for a day, but teach him how to fish and then you feed him for a lifetime. And that's our philosophy at Operation Smile. So it's good to see that we have that shared goal and shared philosophy to make this happen. And then also, it's funny, we do talk about how Dr. Pauline is very, very ambitious with training a number of anesthesiologists in country. And we do appreciate that ambition, because that's how, as Operation Smile, we can tap into that. None of us will be here without all of you sitting here in the room, and for that we say thank you. And that's why we are really energized by Dr. Pauline's ambition, and saying, yes, we would work side along you as you want to train this. He says he wants to train 60 active anesthesiologists by 2024. So we will make it happen one way or the other. We will. And we're also, committed to this. And we do run 2 surgical training rotations a year, typically in April and October, and that is in Rinkwavu. We used to work in Butaro, but then we moved to Rinkwavu based on our partnership with PIH and where the need was. To date, we've had about 18 residents involved in the program, and here Christophe is here as a living testimony to that process. And we not only engage our residents during the surgical training rotations, we also get them to experience part of Operation Smile programs through our next conferences. I did host a couple of Rwandan residents in the Philippines last year as part of that, where we want them to come engage with other residents from other countries that are involved with Operation Smile in a true capacity building fashion, because there's shared learning and collaboration that is needed through North-South partnerships, South-South partnerships, and we help foster that and make sure that it happens. And we've had 22 graduates since the inception, not necessarily our graduates, but graduates of the University of Rwanda who have experienced the surgical training rotations. And I think the skills workshops that we've been able to provide through the surgical training rotations, through participation in all those educational training opportunities, has led to just increased. We say that we help Dr. Faustin and team to build on the plastic surgery rotation of the general surgery residents, and we just have been happy to work alongside the team to do that. And so this is just a breakdown of the number of residents that have been on each rotation. So when Dr. Faustin was at headquarters, he told us actually this year he has 9 surgical residents. So we're excited to just see how we work with those surgical residents through our surgical training rotations. And yes, so of course this was basically the history of that. Was this, whilst this was good, it wasn't sustainable. We had to make sure that we can train enough plastic surgeons in country that can deal with the backlog, that can create that continuum of care, because as you've seen here, whilst Operation Smile, our bread and butter is cleft surgery, we work in that overall plastic and reconstructive surgery capacity. And you've seen that the need more is of burns and those are chronic cases that needs continuous care. It's not just even the plastic surgeon, it's the occupational therapist, it's all of this physiotherapy and things like that. So just making sure that there's capacity in country to take care of patients like those so that they can get the continuous care. Or no child or nobody, in fact, should have to deal with the burns and contractures that is getting worse if they had adequate care at the point of the illness or the injury at the first point. And that's what we're hoping to be able to bridge that gap. So these are the 4 most recent graduates that have completed their general surgical training residency and were part of our surgical training rotations. And I think, if I remember correctly, all 4 of them happen to be in the Philippines for the conference, and they've been assigned to different parts. And we try to keep track. We actually have implemented a monitoring and evaluation tool where we can assess the impact of the trainings, not just the teachings, but that whole experience with residents, and then seeing how that has helped impact.
I was meeting different people, and especially plastic surgeons from across the country. And when I joined the training, midway my training, I was in the 3rd year. I was MO between Operations Man, University of Rwanda. And then I met the people I met in 2012 coming again with a mission of helping us, building capacity, and keeping us with surgical skills in regard to plastic surgery, so that we can help our seniors who are plastic surgeons, but they are, they are few, but they cannot manage all cases. And my understanding is that every training surgeon should have plastic surgery skills, so that at least they can, whatever you do, if we talk about plastic surgery, you understand skin and even something beyond that. Now we are working, we are using the skills that we learned from Operation Smile together with our seniors and plastic surgeons. So we appreciate it, and we know that we do have a long list of people in need of surgical care, especially there are different people with craniofacial defects. They are sick from trauma, burns, road traffic accidents. We do have soft tissue and skin tumors. All those pathologies, they need people who have skills. We in Rwanda have done a hospital survey. We surveyed all hospitals in Rwanda, and we were aiming at seeing where we are in regards to those indicators. And with the findings, the Rwanda Surgical Society, together with the Society of Anesthesia and Obstetric and Gynecology and Ministry of Health, drafted a surgical plan that will help us fix the targets to reach those indicators. We have seen that the 2-hour access coverage was around 80%. Those are they were 100%. However, the surgical volume were 786 operations per 1,000 population, and the surgeon, anesthesiologist, obstetrician providers per 100,000 were 8.03, whereas the targets should be between 20 and 30. So we are still behind the targets. The tracking of postoperative mortality rate was at 76%. However, the providing expenditure and catastrophic expenditure, they were estimated. We wish that providing expenditure is almost zero, but we're at 75%, whereas catastrophic expenditure was 25%.
Private practice. So the purpose of private and public partnership is, of course, to increase the surgical volume as a big indicator of access to surgical care. And we think that if the private practice is developed in the country, this will help the public institution to increase the surgical volume, because we can partner and go to the remote area and to operate together in outreach and other remote missions, and then we can increase the surgical volume. And this, of course, is one of the Lancet Commission indicator about the surgical access to care. Of course, with private partners outside the country, coming back to the National Surgical Obstetric and Anesthesia Plan, as Christoph said, this is when the Lancet Commission on Global Surgery calls the countries to develop national surgical plan. Rwanda was the first to take this opportunity. Now, Rwanda has been able to cost the national surgical plan. We have a draft, and we are planning to do a COSEXA conference in December, and we hope that we will launch the Rwanda National Surgical Obstetric Anesthesia Plan with all those 6 domains, mentioning the need, so that in terms of costing, so that we can have can start this plan. And it's very important, but the big challenge is, of course, the workforce, so that we can increase the surgical volume. And we hope that with the Ministry of Health, Rwanda Surgical Society, Society of Anesthesiologists, Society of Gynecologists, together we can work together and see how we can improve this surgical access to care to the Rwandan population. Thank you.
For me, and I'm happy that's what he thinks, if we are going to do plastic surgery training, we are going to give the full package. So we are going to train people to do reconstructive, but we are also going to train people to do cosmetics, so that when they qualify, they will be confident to be able to do whatever they want. People may say we need more because we have more reconstructive needs. So why do you want people to do aesthetics? But in natural, you are the plastic surgeon. The natural progression of a plastic surgeon, and I qualified in 2011. So even before qualifying, I was a resident. So I could see my teachers, I could see my colleagues back in South Africa. And I realized that the natural progression of a plastic surgeon, he qualified as a plastic surgeon, work 1 to 3 years in public, and goes in private. Believe me, the resident that we are going to train, 90% of the training at least will be constructive. Because at my hospital, I have a backlog of 4 years. It's not 1 year, it's 4 years. Why is it 4 years? It's because, for elective surgery, it's because now I operate three days a week. And I was operating 2 days until recently. And every hospital in the country referred to my hospital for plastic because he just joined as a plastic surgeon. I've been the only plastic surgeon in the country for 5 years or 4. So people come, I put them on my waiting list, but I will have cancers, people coming with cancers. I will have referral from orthopedics. I will have burns, fresh burns. And those people who are urgent, that cannot wait, keep pushing those who are on elective as a backlog. That's how I end up having people. When I call someone from elective, I call someone from that I saw in 2014. And that has been a frustration for me. And that is one of the way to solve it, is to start a training program. So my next move is to negotiate with my hospital to have an operating room just for plastic. because I know that if I have resident, then that operating room can work 7 days a week for elective, even Saturdays and Sunday, because resident wants to operate. And when they know that, even if you're not on the premises, but they know that you are available, they get bold enough to do surgery, as long as you're confident that they will do the right thing.
Currently, we're working in Rwinkwavu Hospital, and among the distribution that I saw here, it's not listed. So we just want to also focus our efforts equally to the national strategic plans that are in place. So when we talk about referrals and we talk about provincial strategic hospitals, how do we suit it into strategic locating of rotations or any other capacity building efforts? And the other thing I would wish to thank Dr. Faustin, because it was coming again and again, clicking in my thinking about, yes, we are doing all the efforts necessary to build capacities, and also in the vision of our country as serving as a center or a hub of excellence in the region in service delivery, because it's kind of the most tapped into resource that we have in the as a country. Go beyond that, as in the 5 years retention plan. Yes, it's good, but as given the ratios that we have, I still think the 5 years and the ratio that we got, like the presentation Dr. Christoph gave us, still needs like some subsidiary retention mechanisms, and I think my colleagues would be happy to, because if we are putting in something to build something that is sustainable, we also have to look into surety of how sustainable this program is going to be, and actually the output of the program. So as we continue discussing, it would be so much of a great interest for Operation Smile to hear from you if there are any other additional retention aspects that we could tap into as a program that would be quite significant. Surgery, to me, doesn't only stop when a procedure is done. It goes beyond that to post-operative care. And I've had several times, like where we work from in Rwinkwavu, like the support staff, that is the nursing team, and GPs themselves, like showing interest of knowing how to like go into wound care, skills building, all those things. So as we move forward, we would also look into like subsidiary supportive approaches to ensure that we give the right full package.
This is a long long-term plan, and of course during the implementation of the plan there will be adjustment of the strategies, so we can see what is the improvement, what is reached as objective, and then from a hospital to another one. And of course the goal is to go down to all district hospitals to be sure that the surgical need is met at the lower level of the district hospital, starting by simple surgery. So that's why I say we have to train surgeons, but also we have to provide, to transmit skills for non-surgeon, non-physician providers, so that they can take care at least those small cases and limit this kind of transfers, flow of movement of patients from their village to the referral hospitals.
And the postal code itself, they even use this picture in their marketing now because they were so happy that we were so happy.
Yeah.
So I just wanted to show you that, and I just wanted to add that I'm very, very glad to hear the discussions around the table about cooperation and working in partnership, because from our side, basically, our job is done. The real work now begins for everyone around this table, and that's why I'm really, really glad to see that we have so much competence around this table, which feels very, very good for the future of the program. And I mean, from our side, we can contribute with a piece of funding and also with competence, such as Jan. And if there is any other competence that you might need, we can definitely see if there's something we can contribute with. But the main work still has to be done here in Rwanda with those partners around the table. So I'm really, really happy to hear that everyone is on that. And even the Minister of Health mentioned that it's a partnership that needs to be done. Me personally, it's always very, very important not to be donor-driven in any program. I mean, this is just not the road we want to walk here. It just makes me really upset when you say what you say, because this is definitely going to be a program that's kind of specialized for the needs in Rwanda. And just like you say, you're the ones that knows the needs in Rwanda. We have no idea in Sweden. We can bring in competence, but we should be very, very careful to tell you what to do. And that is not the approach we want to have here. And the good part of this program is that this donor, this specific donor, is not pushing that, is not pushing us. They're not going to tell us how to do things. On the contrary, they are very much more, they want to see this coming out of Rwanda, not the other way around. We want to contribute with our volunteers and our competence, and it's up to you to decide how you want to use it. But let's not ever, do anything because we think it's what the donor wants. That's totally the wrong approach from my side.
So my first mission with Operation Smiley was in the Philippines. And I was a plastic surgeon. I'm doing a lot of cleft work, but suddenly I came to the Philippines and saw a huge hole in the palate. And in another, because we didn't have any adults, with clefts. So there was my friend was looking at me and he wondered, how would you fix this? And so I said, well, how do you do when you have patients like this? So, and he showed how he used to do, and so I learned a lot from that too. So now I don't have so much problem with that. But the contractors, you have to, in the end, learn about microvascular surgery, because that's the solution you have to have in the end.
As I gather, there is supposed to be a multidisciplinary approach. Other surgeons who are not plastic surgeons, other health professionals who are not surgeons and maybe who are not doctors. But I think there can be other sister programs. Maybe that's another thing altogether that is very different from his plan. And maybe their training needs are not going to be the same. Maybe you may need a CPD or a certificate or something for a theater nurse or a perioperative nurse or a physiotherapist who is going to deal with some of the problems. But for a surgeon, you need a 3 or 4 year MMed program. So in my view, as we narrow down to the details, I think what you're looking at is the next steps for capacity building and etc. Yeah, one of the solutions is his MMed in maybe plastic surgery, but there are going to be other, in my view, there are going to be other solutions, like you may need to just train other professionals without necessarily giving them an academic qualification. And that maybe is going to be offered by someone else or you, but through another approach. So in my view, I was trying to think that as we after lunch, as we go to mapping and engagement and whatnot, we go to the details and say, in order to address this is what we need. We need an MMed in surgery. We need maybe CPDs or short courses for these other people. And then as we set timelines, we say during this period we'll focus on MMed, during this other period we'll do that, during this we are going to bring Ministry of Health on board, you're going to bring someone else on board, or maybe Operation Smile is going to mobilize other resources. So that's the way I'm trying to look at it.
We need a really plastic surgeon. I was asking myself, is there maybe in how we can think apart from this, completing this 5-year program or 4-year program, maybe train some already general surgeon in a like midway, like an entrance of 2 years. This will depend on how the program will be designed. And if you design a program in a way that maybe in the first 2 years they have something which is almost general, and you judge that maybe a general surgeon don't need to have this training. After 2 years he can join just to do 3 last years, 2 years, depending on how long the program will be lasting. Another intervention is a bit connected to what Pauline was saying. It's good, really, we need in whatever we do to focus on the needs of the country. But we have also to be very careful, because we are training people to solve the problem in a country, but as far as education is concerned, we need, there is minimum requirement we have to meet for someone, because everyone we are training is not necessarily going to spend the whole life in Rwanda. Once you get out of the country, you need really to fit in other systems. So I think this is for sure. I know that while developing the curriculum, they considered this to make sure that we are not training like isolated cadres who are specific to Rwanda. Once they get out of Rwanda, they're not fitting in other systems. So we have to consider both. We consider what is, I may call it international standards and whatever, but we put the focus on the needs for the country. Thank you.
We will wrap up and go out of the room when we are not coming back. So we're gonna discuss about the mapping and engagement, commitments and the timelines. So we can do it in any way you want it to be done. So, but if I may start, maybe I will summarize what the Ministry of Health has been saying from the beginning when I have been approaching them. Actually, we did another kind of preparatory meeting before this meeting. So with the officials in the Ministry of Health discussing this. So as the director was saying, they are fully supporting this initiative, and they are committed to make it happen and sustainable. So in terms of what is palpable from their side, they have accepted to us to increase the number of residents we take in general surgery from 8 to 10, so that we can find where to pick the 2 we are going to take for plastic surgery. So in addition to that, they are really open to accept and discuss any proposal on the table about pushing this forward. So to the university side of things, I think they are all out, but still here. So for the university, as the business for them is about academia, and they are also supportive, and that's why I see from the vice chancellor actually of the university, because I wrote to him and I went to see him discussing this project, and he was really very happy and willing to come. Unfortunately, he is now outside the country, and he delegated the principal to be here with us. And the university is fully supportive of the project, and academically speaking, we gonna make it as a university program, which is there to stay. It is not just a 3 years program. It is something which is going to stay even after this grant is done. So, from the Rwandan aspect of things, so we are very happy, very excited, very committed to push this forward, and we now the floor is open. Everyone can comment about that and tell us what's gonna be the engagement and the commitments, and maybe after that we will try to put some timelines to see how we from now we move forward from now to September, when the academic year will be starting, and we hope that time we will be starting with a new program in the University of Rwanda called the Masters of Medicine in Plastic Surgery.
Mentor. So now, if I know UpSmile has some good universities,
Yeah.
When we come for the conference, the next conference, we always meet great professors, showing things they are doing, and wondering there are people who want to help. So another good way to say is to show them that we have a program in Rwanda, and Rwanda is specialized in wound management of the contracture and all those things. So if he can bring the best of his residents who are willing to learn something which they don't have there, then when he get a grant for one of the students, he can also take one of us to go and have a month there. So that things in anesthesia, it's working, because some people are coming. One resident comes here, and in his package they just take a little bit of money to prepare accommodation for our resident, who can also go there, spend a month. So I think if it's something we can also build on, and say we also advertise exchange of residents, exchange of fellows. There is some fellowship programs in America, in global health, plastic and global health. So where the resident enter in the program and is supposed to do 3 months out of US, in a low-income country, to develop a project where he can teach how to do, he should come up with a program of teaching skills, So if he knows that Rwanda has a program, and what he's willing to develop is part of Rwandan program. So his boss can be part of our program. Then when he exchanges his fellow, he can take our resident to his place. So we benefit, both of us will benefit from this exchange. And the UR now is willing to work with such team leaders, like a professor from a department who is willing to offer such exchange, can nominate him as honorary professor for a university. He become part of the curriculum of Faustin as honorary professor, and so he can be exchanging with our student.
Say, really, please say it. And maybe now we can move a little bit and try to be very technical and try to see how we move from here to the next steps.
I think I want to backtrack a bit and just, unfortunately, we did not get like a representative for human resources before.
Yeah.
So what part will they play in this?
Yeah, actually we have invited them. I saw the SMS from Shema just now, but it was sent earlier in the morning saying we got an emergency, and then was asking if the meeting is still continuing so that he can join. So I texted back saying the meeting is still here. Probably, maybe he will join along the course. But the Human Resource for Health is an initiative from the Ministry of Health in the government of Rwanda. It is now 7-year-old now. So at the beginning, that put together many US-based universities around one goal to train a critical mass of specialists in Rwanda. So it started 7 years ago, and then it was in multiple fields of medicine, not only surgery and physicians, also in nursing and other medical related fields. So far as medicine is concerned, the target was about to train around 500 specialists in all medical fields by next year.
if we do not have you coming together, put hands together, and even dream, starting by dreaming to establish the program. Thank you very much. Thank you, our distinguished guest from operations. Thank you very much, our doctors, our surgeons, especially Dr. Foster and Dr. Fura.
We support the initiative, we support the project, we support and we appreciate the partnership, strong partnership with, let's say, Operation Smile, because you are here, but also others who will join either today or tomorrow. So now, having said that, I thank you, first of all, for the invitation. And I want to say, I wish you, on behalf of the Ministry of Health and on my own, fruitful deliberation and a successful meeting. Thank you so much.